The title of this podcast is How Common is Autosomal Dominant Polycystic Kidney Disease? I am Vicente Torres from the Mayo Clinic in Rochester, Minnesota.
And Peter Harris, also from Mayo Clinic.
The prevalence of ADPKD has been controversial. Autopsy studies likely included acquired cysts or other inherited cystic diseases and overestimated the prevalence. On the other hand, clinical studies likely underestimated the prevalence due to incomplete ascertainment. Studies of German and British populations have estimated minimum, that is, prevalence of diagnosed cases of 24 and 39 per 100,000 respectively. Population-based studies in Copenhagen during 1920 to 1953 and in Olmsted County, Minnesota during 1935 to 1980 estimated the annual incidence rates of ADPKD diagnosis. For a highly prevalent genetic disease such as ADPKD, the cumulative incidence rate can be used to estimate the disease expectancy, which by 80 years of age approximates the genetic prevalence. The disease expectancy was estimated to be 80 per 100,000 in Copenhagen and 100 to 250 per 100,000 in Olmsted County.
Recently, the prevalence of PKD1 and PKD2 mutations has been determined in large population sequencing databases such as NOMAD and BRAVO. Prevalence rates of high confidence pathogenic and lightly pathogenic PKD1 mutations were 209 per 100,000. The rates of high confidence pathogenic and lightly pathogenic PKD2 mutations were 59 per 100,000. Importantly, these genetic prevalence rates do not include mutations to other genes than PKD associated with ADPKD or genes associated with autosomal dominant polycystic liver disease or sometimes mild polycystic kidney disease.
In the present work, we have used the Rochester Epidemiology Project and the Mayo Clinic and Olmsted Medical Center radiology databases to revisit the epidemiology of ADPKD in Olmsted County during 1990 to 2016 and compared it to the previous study from 1935 to 1980. ADPKD diagnoses were classified as definite, that is, supported by documented family history or genetic testing, likely, that is, typical cases without this documentation, and possible cases, excluding other cystic diseases, and age, and by age and sex adjusted 6 number above the 97.5 percentile in a healthy control population. Definite and likely diagnoses were considered to be clinically significant. And the age and sex adjusted annual incidence of a definite or likely ADPKD diagnosis was 2.2 times higher during 1980 to 2016 compared to 1935 to 1980, 3.06 compared to 1.38 per 100,000 population per year. The prevalence of definite or likely ADPKD on January 1, 2010 in Olmsted County was 68 per 100,000. This is lower than the estimated genetic prevalence because it does not include undiagnosed cases and because the genetic analysis likely identifies changes that may not be pathogenic. When possible cases were added in Olmsted County, the point prevalence in Olmsted County was 124 per 100,000, which is closer but is still below the genetic prevalence.
So, in summary, the present study shows that ADPKD has been diagnosed more frequently in Olmsted County during the last 4 decades than in the previous 4 decades. The prevalence of diagnosed cases in Olmsted County is higher than those reported in the British and German populations, possibly because of more comprehensive ascertainment. A large gap between the prevalence of genetic cases and genetic prevalence suggests that ADPKD, particularly mild cases, are underdiagnosed or that significant genetic events are overestimated. When possible, diagnoses established by a retrospective review of radiological reports and images are added. Prevalence rates approaching those, but still below the genetic prevalence, were determined, likely because the radiologic ascertainment of the population was far from complete. Further studies utilizing genetic testing will be needed to determine to what extent ADPKD due to PKD1 and PKD2 and other genes are likely the cause of these yet unidentified cases.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.